Welcome to this explainer on surgical endocrinology, specifically focusing on thyroid and parathyroid clinical rounds. Our goal today is to jump right in and look directly at the evidence, the data, and the core physiological principles that actually drive surgical decision-making.
We've got three main sections to cover: preoperative pharmacology, cytology and malignancies, and endocrinology basics. Let's get right into it.
Section 1. Preoperative pharmacology. We're looking at preventing thyroid storms.
Here's our first case. We have a patient with a large multinodular goiter planned for surgery. Which option is correct regarding carbimazole in preventing a thyroid storm? The correct answer is A. A 30 to 40 milligram dose of carbimazole is the treatment of choice. Preoperative preparation of a hyperthyroid patient absolutely mandates rendering them biochemically euthyroid. If we operate on an inadequately prepared thyrotoxic patient, the physical stress can trigger a massive surge of thyroid hormones. That leads to a thyroid storm, causing extreme fever, malignant arrhythmias, heart failure, and honestly, even death. So an initial daily dose of 30 to 40 milligrams of carbimazole is our standard strategy to inhibit that hormone synthesis.
Moving on, our patient is being prepared for surgery. Which of the following drugs is known to reduce the vascularity of the enlarged thyroid gland? The answer here is E, potassium iodide. You see, while drugs like carbimazole block hormone synthesis, they can actually increase the vascularity and fragility of the gland if used alone. Exogenous administration of high-dose iodine, like potassium iodide, induces what's called the Wolff-Chaikoff effect. This causes a marked involution of the thyroid parenchyma, drastically reducing its blood supply and making the gland much firmer. And that makes safe surgical dissection so much easier. So, looking at the timeline, carbimazole is typically administered for 8 to 12 weeks to get the patient to a steady euthyroid state. Then, exactly 7 to 10 days before surgery, we introduce potassium iodide. The timing here is absolutely critical. Iodine therapy must not exceed 14 days, otherwise the thyroid gland will literally escape the Wolff-Chaikoff effect, and you'll trigger a severe rebound flare of thyrotoxicosis known as the Jod-Basedow phenomenon.
All right, Section 2. Cytology and malignancies. Let's talk about diagnosing a thyroid mass.
Here's the scenario. A patient with a suspicious swelling of thyroid origin undergoes a fine needle aspiration. The report comes back labeled as Thy5. What does this denote? Well, clear cytology is absolutely crucial for surgical planning, and the correct answer here is D, malignant.
To put that in context, the UK Royal College of Pathologists' Thigh Classification Matrix is our standard histopathological coding framework. Thy1 is non-diagnostic. Thy2 is non-neoplastic, like a benign nodule. Thy3 shows atypical features requiring a diagnostic hemithyroidectomy. Thy4 is suspicious. But a Thy5 designation, that provides definitive cytological confirmation of an active malignant neoplasm. When you see Thy5, it mandates immediate oncological surgical planning, like a total thyroidectomy.
Next question. Which of the following is the most common malignant thyroid neoplasm? The correct answer is A, papillary carcinoma.
The sheer scale of that dominance is wild. It's 80%. Papillary thyroid carcinoma accounts for roughly 80% of all primary malignant thyroid tumors in iodine-sufficient regions. But the good news for patients is that it generally exhibits an excellent long-term prognosis. It follows a very indolent, slow-growing course, spreading mainly via the lymphatic system to regional cervical lymph nodes. Notably, exposure to ionizing radiation during childhood is a major predisposing risk factor here.
Let's apply that. A middle-aged patient presents with a 3 by 2 centimeter nodule on the left thyroid lobe. There are multiple ipsilateral palpable lymph nodes, and she has a history of childhood radiation. What's the next best step? Given what we just discussed, the answer is A, fine needle aspiration. The combination of a solid nodule, enlarged lymph nodes, and a radiation history basically screams papillary carcinoma. Fine needle aspiration biopsy is the most accurate, cost-effective initial diagnostic test we have before formulating any surgical margins.
Try this one. A 44-year-old female presents with an asymptomatic neck mass. She also has a history of radiation to the neck for a childhood thymus issue. What's the next step? Again, the answer is B, FNAC, or fine needle aspiration cytology. In the past, surgeons might have relied on a radionuclear thyroid scan, but scans just can't differentiate benign from malignant cold nodules with enough precision. FNAC safely supersedes those old-school scans and allows us to plan a definitive single-stage surgery.
Shifting gears slightly, which of the following is the most common etiology of acute thyroiditis? The answer is A, bacterial.
Acute suppurative thyroiditis is a rare but incredibly painful inflammatory condition characteristically driven by pyogenic acute bacterial infections, most commonly Staphylococcus aureus and Streptococcus pyogenes.
Now, the critical takeaway here is exactly why this condition is so rare. The thyroid gland is actually highly resistant to pyogenic infections. It's got rich vascularity, abundant lymphatic drainage, an encapsulated architecture, and a naturally high iodine concentration. So if you see a child or young adult presenting with recurrent acute bacterial thyroiditis, you need to look aggressively for an anatomical predisposition. Specifically, you're looking for an underlying pyriform sinus fistula tracking directly from the pharynx right into the gland.
Section 3. Endocrinology Basics, with a focus on the parathyroid.
A patient with high TSH levels and low T3 and T4 levels is most likely to have which pathology? The correct answer is E, myxedema, which is the advanced clinical presentation of primary hypothyroidism.
In primary hypothyroidism, the low circulating T3 and T4 levels mean there's a complete loss of negative feedback to the brain. The anterior pituitary notices this and triggers a massive compensatory upregulation of TSH, hence the high TSH. Contrast that with thyrotoxicosis, where massive amounts of T3 and T4 suppress TSH to nearly undetectable levels. And then there's subclinical hypothyroidism, where TSH is elevated, but the free T3 and T4 levels are actually still technically within normal baseline ranges.
So how do these hormones actually travel through the blood? To which of the following molecules does thyroxine especially bind in serum? The answer is C, thyroxine-binding alpha-globulin. Once secreted, over 99% of thyroid hormones are tightly bound to circulating plasma proteins, and T4 has the highest affinity for this specific alpha-globulin synthesized in the liver.
Breaking that down, thyroxine-binding globulin carries about 70% of the bound T4. Transthyretin takes about 15%, and albumin takes the remaining 15%. But here's the absolutely critical physiological rule. Only the unbound, free fractions of these hormones are biologically active and capable of actually crossing cell membranes to do their job. If a patient's liver alters protein synthesis, like during pregnancy, the total T4 levels shift dramatically, but their free T4 kinetics remain completely normal.
All right, back to the OR. Intraoperative levels of which of the following are used to determine the complete removal of a parathyroid adenoma? The answer is C, serum parathyroid hormone levels, often called IOPTH.
The crucial point here is the Miami criteria, centered around the number 10. Circulating intact parathyroid hormone has an incredibly short physiological half-life of just 3 to 5 minutes. Because of this, surgeons can measure it in real time. A successful curative resection is confirmed when the IOPTH level drops by more than 50% from the pre-incision baseline exactly 10 minutes following the extraction of the adenoma. Tracking calcium just doesn't work for this because calcium levels take hours to days to normalize.
Let's look at our last case. A 38-year-old woman presents with weakness, bone pain, and a dangerously high serum calcium level of 15.2 milligrams per deciliter. Hand films show osteitis fibrosis cystica. What's the most likely cause? The answer is E, primary hyperparathyroidism, which is usually driven by a solitary autonomous parathyroid adenoma. When you see osteitis fibrosis cystica on films, you're looking at severe bone destruction. Excess parathyroid hormone excessively stimulates osteoclastic bone resorption. It literally pulls calcium out of the skeletal matrix and dumps it into the extracellular fluid pool, leaving behind tapered digits and localized brown tumors filled with fibrous tissue. It really makes you wonder, doesn't it? How long can a quietly autonomous, tiny millimeter-sized parathyroid adenoma drain an entire human skeletal system before a patient finally walks into the clinic? It's a profound reminder of the delicate, unseen balance of calcium homeostasis occurring in our bodies every single second.